Hello and welcome. Today is my last class on immunization. The topic of discussion today is optional vaccines. Optional vaccines, these are not included in the routine immunization schedule, but still they are recommended because they protect against disease that may be less common but still serious. So the recommended common optional vaccines are influenza vaccine, varicella zoster, hepatitis A, meningococcal vaccine, MMR, mumps vaccine, rabies. So I'll discuss optional vaccine. I already told you those are not included in the routine immunization program and always given on optional basis under guidance of your doctor, treating doctor. You can take the recommended vaccines. Starting with influenza vaccine, also known as flu shot. This protects against influenza, which is causing a contagious respiratory illness by virus known as influenza viruses. So this is against the influenza virus infection. And the types of vaccines available is number 1, inactivated influenza vaccine, which is injectable vaccine, and this is most popularly commonly used. Number 2 is live attenuated influenza vaccine. This is given as a nasal spray, so not very commonly used. And third one is recommended influenza vaccine. So I'll be talking about inactivated influenza vaccine. The recommendation is for children 6 months and older, and very elderly adults, pregnant women, and in people who are having chronic illnesses like asthma, diabetes, nephrotic syndrome, chronic kidney disease. So all these conditions, it is recommended. This vaccine is given annually before the flu season starts. So usually flu season is autumn or winter, but the timing varies by countries. Dose 0.5 ml per dose. 6 month to 8-year-old children, 2 doses are required at 4 weeks apart. That is 1 month apart you give 2 doses when you are giving the vaccine for the first time to the child. After that, every year you are supposed to give. And 9-year and above 9-year-old children, just a single dose every year. Site 6 month to 12 month, anterolateral thigh, and 12 month and above deltoid muscle, upper arm. And then you give route of administration is intramuscular. Don't give this vaccine at the gluteal region because it has less effective absorption at that site. Next vaccine is varicella zoster vaccine. This is against chickenpox. It is important to vaccinate because it is a highly infectious disease causing lots of complications. And the risk groups are neonates, immunocompromised people are more prone, like HIV, leukemia, disseminated varicella disease occurs in these conditions. So immunocompromised people should get varicella vaccine. And it also causes shingles in the long term. And pregnancy also, during pregnancy if a mother is infected by the varicella, then there might be birth defects in the child, the baby born to this mother, with the microcephaly, deafness, atrophied limbs known as varicella phytopathy. So to prevent all this, you're supposed to vaccinate. It is live attenuated vaccine which protects against chickenpox, that is varicella zoster. It comes as a monovalent vaccine alone or in combination with the MMR as MMRV. It is marketed globally in the name Varilix and then in US by name Varivax. And there is another vaccine known as Zostavax, which is a larger than normal dose of Varivax. And now this vaccine is recommended to all age group more than 1 year who never had chickenpox. Number 2, high exposure risk groups are supposed to get this vaccine, and those high risk group is susceptible, healthy, close contacts that is parents and the siblings of the patient, the healthcare workers, teachers or daycare workers who may come in contact with the patient having chickenpox, and to the travelers to higher exposure risk area. And in chronic diseases like nephrotic syndrome during remission, sickle cell anemia, chronic lung disease like asthma, chronic heart disease, chronic kidney disease, all these conditions, these children, they should get the chickenpox vaccine. And post-exposure prophylaxis, that is given within 3 to 5 days after the exposure to a patient having chickenpox. So these are the recommendations. And not recommended, chickenpox vaccine is not recommended in children who is having severe immunodeficiency, especially T-cell mediated. So example is HIV. Also in children who are having high dose steroids or chemotherapy, pregnant woman, and serious allergic reaction to any component like gelatin, neomycin with the first dose of chickenpox, this is contraindicated. And who just got blood products or transfusions with immunoglobulins, for these children, this vaccine should be deferred for at least 5 months, 3 to 5 months. Then if you already had chickenpox, then no need for vaccination. You get a lifelong immunity with the natural infection. Administration dose is 0.5 ml, and then mode of administration is subcutaneously. Children more than 12 months till 12 years, 2 doses are always recommended. First dose you give at 12 to 15 months of age, and second dose at 4 to 6 years of age. Whereas older children and adults who is 13 years or more than 13 years, 2 doses are given 4 to 8 weeks apart. There is 90 to 95%. This is 90 to 95% effective in preventing the severe diseases. So it is a very effective vaccine, and the protection it gives you is 10 to 20 years. It's a long-term protection this vaccine is giving. Storage as other vaccines 2 to 8 degrees Celsius in the refrigerator, and do not freeze this vaccine. It is light sensitive, so protect from light. After reconstitution, use immediately. If not used, discard within 30 minutes. Maximum is 1 hour. Next vaccine is hepatitis A vaccine. This is against hepatitis A virus infection, and you can give this vaccine to children above 1 year age. Vaccine is available in two forms or 2 types. Number 1 is formaldehyde inactivated vaccine, hepatitis A vaccine. Another is live attenuated virus vaccine. Efficacy this gives is 95%. It is also good after 2 doses. It can be given, you just remember, it can be given with the MMR, DPT, IPV. It is recommended for high endemic regions. So in place where hepatitis is very commonly occurring, this place the population should get hepatitis A vaccine. And side effect and contraindication of this vaccine is as usual of other vaccines. The commonly used vaccine is formaldehyde inactivated hepatitis A vaccine. The adjuvant in this vaccine is aluminum hydroxide. And the age you should be vaccinating is after 1 year, so that is 12 month to 18-year-old children. Dose 2 doses for best protection. First dose at 12 to 23 months, and then booster second dose you'll give 6 to 18 months after the first dose. The dose is 0.5 ml, and the route is intramuscular in the thigh for infants less than 12 months, and then upper arm deltoid for the older children. The protective antibodies, they start appearing 2 to 4 weeks after the first dose, and the protection is also long lasting, so that is at least 10 years. Next vaccine is against Neisseria meningitis, that is meningococcal vaccine. Neisseria meningitis, it causes serious illnesses like meningitis, septicemia. It has 13 clinically significant serogroups according to antigenic structure of their polysaccharide capsule, but the 6 serogroups A, B, C, Y, W35 and X are responsible for all disease in the humans. and out of 6 also mainly ACYW135 is more important. So the vaccines available are against these 4 serotypes. It is available as a bivalent or quadrivalent vaccines which targets the serogroups A, C, W, 135 and Y. So number 1, there is a bivalent vaccine available against A and C serotype. This is a polysaccharide vaccine and not used anymore. Number 2, polysaccharide vaccine, meningococcal polysaccharide vaccine 4. This is a quadrivalent vaccine and this is an older one, so usually not used. If conjugate meningococcal vaccine is not available, then only it is used. So number 3, this is a meningococcal conjugate vaccine. So this is the vaccine which is used. This is also quadrivalent vaccine against ACW135, and then the common brands available is Menactra and Menvio. This is commonly used. Number 4 vaccine is Menv vaccine. This is against serogroup B. So this is also not commonly used. Bivalent that is against serogroup A and C. This was approved by FDA in June 14, 2012 for 6 weeks to 18-month-old children, and this is against the serogroup A and C. This was the first meningococcal vaccine which could be used for infants less than or as young as 6 weeks old. And the polysaccharide vaccine, this vaccine is available since 1970s, but it is not used. It is used only if the conjugate meningococcal vaccine is not available. So the main conjugate vaccine which are in use is available in 2 forms. One is Menactra. This is the first meningococcal conjugate vaccine which was licensed in US in 2005. Then comes number 2, Menvio, which was licensed in 2010. So these vaccines are, in this, antigens are conjugated to a diphtheria toxoid polysaccharide protein complex, resulting in enhanced duration of protection and increased immunity. All the conjugate vaccine, it is giving an enhanced duration of protection and increased immunity. So this vaccine is approved for 2-year to 55-year-old children. Below 2 years you cannot give this vaccine. So above 2 years to 55 years you can give this vaccine. Dose 0.5 ml single dose, route IM and protection 5 years. For children less than 2 years, bivalent vaccine is safe. Indication on the high risk group who should be getting meningococcal vaccine. Number 1, complement deficiency C5 to C9, strongest indication. Otherwise they get recurrent meningococcal infection. Primary immunodeficiency disorders, severe combined immunodeficiency disorder is the example, and then HIV infection which is acquired immunodeficiency, asplenia or splenectomy conditions. Asplenia occurring in sickle cell disease or any child who is undergoing splenectomy. Before going to splenectomy, you should be vaccinating this child with the meningococcal vaccine. They are very high risk groups. Immunosuppressive therapy, children who are getting immunosuppressive therapy like nephrotic syndrome, leukemias and many other conditions where they get steroid or any other immunosuppressive therapies like connective tissue disease, all those. And malignancy post-transplant patients also should get this vaccine. All residents of the epidemic area and contacts of index case, family members, school, college students who is coming in contact with the index case, they should get this vaccine. And people who are working in the microbiology lab, they should also be vaccinated. And even the doctors who come in contact with the index case, they should be also getting this vaccine. Next is MMR vaccines, measles, mumps, rubella. This is a mixture of 3 live attenuated viruses. This was first developed in 1960. Many places, many countries, this is under the schedule vaccine. But in Nepal, we have MR vaccine, not MMR. So this is recommended for children 15 to 18 month old, any age, and preferable is up to 5 years. Both sex should be getting this vaccine. healthcare workers should get, and women of childbearing age, it's very important they get this vaccine. It is supplied freeze-dried, lyophilized, containing live attenuated measles virus with the Edmonton Jacob strain, mumps virus, Gerald Lynn strain, and rubella virus Wisla RA27/3 strain. These 3 attenuated virus strains are cultured separately in appropriate media and then mixed before being lyophilized. And before injection, it should be reconstituted with the solvent which is provided along with the vaccine. The reconstituted vaccine, it contains in a single dose. Single dose is 0.5 ml. So here more than 1000 CCID50. So CCID50 is cell culture infectious dose. So CCID50 means amount of virus which is required to infect 50% of the cell cultures. And similarly, more than 5000 CCID50 of mumps virus, more than 1000 CCID50 of rubella virus. Diluent is sterile water reconstituted with the auto-disabled syringe. Root subcutaneous, site is upper arm or the thigh in the younger children. And then dose is 0.5 ml. And 2 doses should be given. First dose at 9 to 12 month age. Second dose 4 to 6 years later, or at any time of 4 to 8 weeks interval after the first dose also you can give. After reconstitution, vaccine should be used immediately. If it is not immediately used, then it should be stored in dark place at 2 to 8 degrees Celsius for no longer than 8 hours. After that, you have to discard this vaccine. Monovalent mumps and rubella vaccines are also available. Both are live attenuated vaccines, but these are rarely used these days. It is of use only during the outbreak. During outbreak control only, sometimes monovalent vaccines are required. Otherwise, it is not used. Dose, route, side effects are all same as MMR. Last is rabies vaccine. In absence of post-exposure prophylaxis, about 3 lakh people would die of rabies in Asia and Africa each year. So it is very important. This vaccine should be given if the person gets an animal bite. It is used to control rabies. There is pre-exposure and post-exposure prophylaxis for rabies vaccine. Pre-exposure vaccine you are getting, pre-exposes before you are exposed to the rabies cases. So high risk population should be getting this vaccine. So this vaccine you get at 0 day, 7 day and 21 or 28 days. 3 doses. And post-exposure vaccine 0 day, 3 days, 7 day, 14 day and 28 days. So this is given at 5 days or 5 doses should be given once you are exposed to rabies. Rabies vaccine was developed first in 1885 and first used in human in July 6, 1885. The categories or different types of rabies vaccines available is, number 1 is nerve tissue vaccine that was developed in 1885, is not in use these days because of its high side effects. This is not used. The ones we are using is the modern cell culture vaccines. So this is inactivated vaccine and this is being used. So these are 3 types. Human diploid cell vaccine which was started in 1967 and this is costly, so usually not available in many places. Purified chick embryo cell vaccine and purified varicella rabies vaccine. This is mostly used. These 2 are mostly used, and then most commonly used is purified varicella rabies vaccine. The differences between these WHO approved 3 types of modern vaccines against rabies. So this can be used in pre-exposure and post-exposure as a pre-exposure or post-exposure prophylaxis. Full name is human diploid cell vaccine. PCECV is purified chick embryo cell vaccine. PVRV is purified varicella vaccine. The cell source is human cell, chicken embryo, and then vero is, that is, monkey kidney cell. Then use is both in pre and post exposure prophylaxis. This can be used. Cost is human diploid cell vaccine is expensive, so usually not available, and other two are moderately expensive. Availability is very limited because of its cost, many times not available and many times not affordable also. And other two are commonly used, but very commonly used is purified varicella vaccine. Dose is for human diploid cell vaccine 1 ml intramuscular. If you give intradermal, 0.1 ml, and PCECV is also 1 ml IM intramuscular, and if you reuse the intradermal route, 0.1 ml is the dose. And then purified varicella vaccine dose is less, that is 0.5 ml intramuscular or 0.1 ml if you are doing intradermal injection. So this is being very commonly used. Even in Nepal we use this. Indication for post-exposure prophylaxis: if the patient is bitten, so after the animal bite, the domestic animal is observed. If they develop rabies in 10 days, it is highly recommended. And then pre-exposure high-risk children are veterinarian doctors, animal handlers, and zookeepers, lab personnel handling rabies, and pet owners, postage and delivery personnel, and staying in endemic rabies area. So these people are at high risk, so they should be getting pre-exposure prophylaxis. Post-exposure prophylaxis dose 0.5 ml to 1 ml depending on the brand you are using. Schedule is intramuscular day 0, 3, 7, 14, 28, 5 doses. If you are giving intradermal, then you give 4 doses, that is 0 day, 3 day, 7 day and 28 day, but every visit you get 2 sites. Every visit 2 arms you are getting intradermal injection 0.1 ml. And site will be deltoid or anterolateral area of the thigh. Developing countries we use intradermal, so dose is less, 1 ml, 2 sites, both deltoid muscle. Pre-exposure prophylaxis. The vaccine commonly used for this is Rabipur or Vero-Rab. So purified chicken embryo cell vaccine, Vero-Rab is purified varicella rabies vaccine. This is most commonly used. So the schedule for pre-exposure prophylaxis, the current standard WHO recommendation is 2 doses, 0 day and 7 day. But many places they are still practicing the old schedule, that is 0 day, 7 day, 21 day, 3 doses. And a booster 1 year later only for high risk. Dose is 0.5 to 1 ml depending upon the brand you are using. Route is intramuscular, intradermal, again depending upon the protocols. Okay, contraindication for all the vaccines I have discussed is with the known hypersensitivity or anaphylaxis to any component of the vaccine, you should not give the following doses. And there are no serious side effects, and side effects are very rare for all the vaccines I have mentioned. They have only mild side effects like local site redness, pain, swelling, soreness, and sometimes systemic symptoms like fever, mild rash, myalgia, nausea, vomiting, abdominal pain for all these optional vaccines. So they are very safe. You should be vaccinating where required. So thank you. I end my class today. So always remember, optional vaccine is not compulsory, but it is beneficial, and decision should always be made after you consult, you get a medical guidance from your doctor. Thank you. I hope all the immunization classes were helpful for you. It is important for exams and even important in your later practicing life. Thank you.